Let's go ahead and talk about the elephant in the room, which is medication-related costs. So how have we been doing over the past couple of years related to medication cost control? I've been in managed care for about 20 years, maybe a little over 20 years. And as a pharmacist, working hard to make sure that people have access to affordable drug coverage, and that we can take steps to lower the cost of prescription drugs. So let's look at the track record. This graph represents prices from 2008 to projected into 2022. How have we been doing? Well, I think there's room for improvement. Medication prices certainly continue to be in the news. They continue to rise and have impact on consumers. So let's look at some of the drivers of medication cost increases. And I'm going to talk about the drivers that maybe are a little bit different than you might think. And we often hear about innovation, increased use of medications, and those are all true and drivers, and there's lots on that topic. But what I want to talk about for us is the effect of some of our benefits and benefit designs. A particular topic that was discussed quite a bit in 2019 were medication rebates. And you may have heard the conversation that HHS, the United States Health and Human Services, and CMS, Centers for Medicaid and Medicare Services, had considered taking steps to eliminate or reduce how rebates, prescription drug rebates, were used in payments for benefits. And long story short, cut to the chase, rebates are here to stay. During that evaluation period, it was determined that the government really would potentially cause more disruption by eliminating rebates, and might not actually help consumers if they implemented programs to mandate the elimination of rebates. We also have heard that PBMs and health plans are attempting to use those rebates to benefit, more specifically benefit the consumer by having those rebates available at the point of sale. Let's talk about what rebates are, how they work, and I'll unpack this slide for you a little bit. So first of all, let's talk about how a rebate might work. So on the left side of the slide, we see a drug company or a manufacturer. And when a new medication is approved by the FDA, oftentimes a manufacturer will approach a pharmacy benefit manager, and they will come to an agreement or have a discussion around how a medication is going to be covered. So oftentimes a manufacturer will pay a PBM a fee in order to have that drug listed on that preferred medication covered list, called a formulary. So the fee will be in the form of a rebate oftentimes. And this makes sense in a way, because the PBM is attempting to use their purchasing power, the pool of healthcare purchasers that they've assembled, to negotiate a lower price from the manufacturer for the members. So the PBM will, again, use their purchasing power, negotiate a lower price from the manufacturer, and the way they do that often is in terms of a rebate or a discount, and that is also perhaps considered a fee that the manufacturer pays the PBM in order to have their medication covered and coverable under that PBM benefit. So those dollars in the form of a rebate may be passed through back to the health plan. In this case, the health plan might be an insurer, it might be an employer-sponsored benefit plan, but the health plan can use those rebates, again, to offset some of the costs of coverage. So the health plan's purchasing power, the amount of rebate they can get, is often driven by the size of that plan, the size of that purchasing pool, and that can drive deeper discounts and greater rebates. In this example, we have a patient at the center who is paying both the health plan for their coverage in the case of an insured population, an insured patient, or perhaps the employer is paying the health plan for the premiums in this case. Now the patient, when the patient goes to the pharmacy, they're going to pay the pharmacy for their co-payment for the prescription drug. The dilemma occurs when the rebate that flows back to the health plan might not impact the patient's drug cost at the time of the prescription. So in other words, the rebate might not be applied to the price and reflect the price that the patient actually pays. In some cases, the patient might receive the benefit of that rebated drug because in order for the drug to be preferred on that formulary, a rebate would be necessary, and then that means that that drug is available at a preferred copayment. So the patient might pay a lower cost in the form of a preferred copayment in that circumstance. But that's not always the case. If the benefit perhaps is a 20% coinsurance, the patient's paying 20% of the unrebated price of that drug. And so the dilemma that occurs is that patients are paying a copayment based on the full amount allowed rather than the rebated price in many circumstances. So what are the downsides of rebates? Well, rebates could be perceived as a tax on the sick or a penalty on the sick, and that's certainly something I've heard. Since rebates that are then used to perhaps lower the premiums are funded by the prescriptions of those rebated medications that are in many cases paid for by the person who is using that medicine. So in some cases, the people who are using the benefit are subsidizing, if you will, are perceived as subsidizing the overall prescription benefit. The other concern that I want to raise your attention to is that rebates might be guaranteed. They might be as part of a prescription benefit. They might be guaranteed in a benefit contract, and then that can then reliably offset prescription benefit costs. So what that means is very much like your tax return, right? So if you have the government withhold a certain amount of your money, you'll come to count on your tax return after you file your taxes on April 15th. And I know some families rely on that tax return, and some some employers would rely on, or health plans would rely on those rebates in order to fund and have an impact on the benefit costs. The downside is that the absolute dollars that you're paying in order to get that rebate aren't often tracked clearly. So what we see are rising prescription drug prices over time. They drift up because those are being used to fund rebates on the back end. What's a specific example of how this could potentially impact a patient? So we have two examples listed here for two different types of medications. I'll walk through an example. Forgive me if the example is not, these are fictitious examples. They're not, there's definitely different benefit designs that can unfold and handle these circumstances, but let's look at some of these examples. In one case, on the left, we have rheumatoid arthritis, and we see Humira and Orencia. Both are A-graded drugs to treat rheumatoid arthritis, meaning they have very good evidence that they improve symptoms for those conditions. In this case, Orencia is priced slightly lower than Humira based on the amount allowed based on prescription claims data that we've seen. So if you see that if, for example, in this example, if Humira is a preferred product and a consumer has to pay a 20% coinsurance, the view of the consumer is that they are being required to pay a higher price drug, or being required to pay for a higher price drug. Now, on the back end, the rebate might lower the cost overall to the plan, but from the consumer's view, they're paying 20% of that total cost, that total amount allowed. In the case of hepatitis, the difference could be even greater. Now, these are very, very expensive drugs, and I'll acknowledge that many times people hit their out-of-pocket maximum, and so the point becomes moot. But this will hold true for lower cost medications as well. If a drug has a high price, in the case of Harvoni, and it's preferred and it's required that the person uses Harvoni because that's the preferred drug under the formulary, and a person's paying a 20% coinsurance, they're going to pay a lot more out of pocket than if they were to use the alternative, Mavorette, and pay 20% of that cost. So you could see that if a person's paying a percentage of the overall cost, the higher cost medication can certainly impact how much that patient's paying out of pocket. And it can contribute to rising costs over time. So the lesson that we're seeing and what we're observing in continued rises of prices over time is that short-term saving strategies might not lead to sustained cost control. So I would recommend that benefit plans promote medications of the lowest net cost and of good clinical value, and attempting to do that with as little reliance on rebates as possible. By encouraging true price competition in the marketplace and encouraging consumers to select drugs that are lower price, that can drive prices down at the manufacturer level and can also increase the need for high quality medications. So again, the point is to pick a benefit plan that selectively utilizes rebates, perhaps on those medications where the price of the drug compared to its competitors is comparable, and not when the price of the drug is significantly elevated and with a dramatically elevated rebate, because that can have a potential adverse impact on consumers. So let's look at another concept that seems to be unfolding. I would say that there's two medication markets currently that exist. And as you think about prescription benefits, they're going to need to support both of these types of medication marketplaces. On one hand, there are medications that you are probably familiar with, and some of those examples I listed in the previous slide, where there are relatively few options. They're high cost options. And those medications are priced on a value description. I'll go into more detail around that, what that means. But suffice it to say that for some conditions where there are few treatment options, how those medications are priced is different from other medications or other conditions where there are many choices. In the second scenario, where there are many choices, a free market type of approach can help drive down prices. And I'll walk you through an example of that, and we'll see data that shows that greater the number of options available to a consumer, and if the consumer is able to select those options, prices can actually go down. And it also raises the question of quality. So let's go back to that first example or that first market type of specialty and value pricing, and we'll walk through an example of ICER, the Institute for Clinical and Economic Review. They are a group that reviews medications and assigns and describes a value of those medications. So we'll play a short video and walk you through ICER. We might have to email. This video doesn't seem to be working, so we'll skip on, and I will do my best to summarize the video. But suffice it to say that the way this works is there are a group of scientists, non-biased scientists, who are not affiliated with the pharmaceutical manufacturer necessarily, or with health plans. They're an independent entity. And those scientists will take input from the manufacturer, from employer groups, from health plans, from patients, and from providers, and try to understand what is the value that a medication will provide to the patient and to society overall. And taking this approach can help inform a fair price for the medication. The alternative is that the price is maybe not ethically imposed, and we've certainly seen some examples in the news over the past 10 years or so where a manufacturer might come up with an unfair price, an overly burdensome price on medications. So what ICER or other groups like ICER is attempting to do is to take input from a variety of stakeholders and come up with a fair price based on the drug's value. And they do this for medications that are usually rare diseases with limited choices, limited treatment choices. Oftentimes cancer medications can fall into this value price bucket depending on how well that medication works. And then precision medication therapies or precision medicine therapies like genetic treatments, genetic gene therapies as an example. And we'll go into the example on the next slide of what those gene therapies might look like. So two examples of extraordinarily expensive medications: Luxturna for an inherited retinal disease that can cause blindness, and the treatment is around $400,000 per eye. Zolgensma, which is used for spinal muscular atrophy, a genetic condition in small babies, $2 million per treatment. Now, these are gene therapies. These are extraordinarily sophisticated, extraordinarily complex, using the most cutting-edge science in order to treat these diseases. So they are very, very expensive, and there's a very small number of people who can benefit from these drugs, and the price reflects that. So what ICER does is they take into consideration the effectiveness of the drug, how many people are affected by the drug, and try to come up with a price that can help be determined as fair. So let's walk through a quick example of a medication where ICER has had a significant impact on the price. So one example is Praluent, which is a medication for cholesterol. And when this medication came to market, it was priced around $14,000 a treatment. After ICER reviewed the medication, they thought the price should be somewhere around $4,500 to $8,000. And after that evaluation came out, the manufacturer did work with pharmacy benefit managers and health plans and lowered the price in the form of a rebate, in large part influenced, I believe, by ICER's analysis. So what we see are for now cholesterol, high cholesterol isn't uncommon, but at the time this was for a limited indication for a very relatively small number of people. And so as ICER has gone through their processes, we've seen that it does impact the price that a manufacturer will charge. Now, these are very, very high cost medications, and as such, employers are going to grapple with how these are covered. So one way that, so as we look to how employers are anticipating coverage for these medications, one is this concept of a government-sponsored benefit program for specialty medications. So according to a survey of employer groups, a majority of employer groups would be interested in having some sort of a national program that covers these very rare, very expensive medications at a national level. Now, there is also a non-government sponsored program that has come to market in response to these high costs. It's called the Embark Benefit Protection. It was developed by Express Scripts and Cigna. And this is a commercially available product that spreads the risk out among employers. And the goal there is that it has predictability in terms of cost for the employer, and a low or no out-of-pocket expense for those patients that are affected. So the key point here is that these are rare diseases, value pricing might be needed, and that because the cost is so great, it might have to be spread over a large population in order to make it affordable. Certainly medications of $400,000 a treatment or $2 million a treatment are not something many employers can just absorb. So when this is necessary in your population, some of these additional programs that are coming down the pike might need to be considered. So let's look at the second medication market type, which is really when there are multiple medication options available. And in this, I call it it's just a competitive free market. And what we see in this slide here is that as the number of products increases, the cost goes down over time. And so this specific example is looking at generic medications and how many generic manufacturers are putting a drug product in the market. So we see 1, 2 to 10 or more. And when you get to about 3 generic manufacturers, the price really starts to be significantly lower than the innovator product. Now, what we see this sometimes with branded medications, where as more branded medications come to market, the price might go down, but oftentimes the price goes up, and that's in large part, I believe, because benefits are not encouraging competition. What we see when it comes to generic medications is the price does come down, and we'll talk a little bit about why we see the price come down in generics and why we're not seeing it in brands, and that we can make changes to the benefit structure and through increased transparency and shopping to mimic the results we're seeing here with generic medications. So what are the characteristics of a functional medication marketplace that allows for this competition to drive prices down? Well, the first thing we need is transparency. Consumers need to know what are the choices that are available, what are the prices of those choices, and what's the quality of those choices. If consumers don't have access through transparency, if they don't know what things cost and how well they work, we're not going to have a functional marketplace. In the case of generics, generics are brought to the patient often by the pharmacy. So the pharmacist is letting the patient know there's a lower cost alternative. It's a very easy switch. The next characteristic is it's a reasonable choice. So in the case of generics, generics are a very reasonable choice because they're viewed by the FDA as therapeutically interchangeable. The pharmacist can switch them, and so it's a reasonable clinical choice. In the medication, in other medication conditions, or when we think about brand-to-brand choices, many times there are multiple choices that are reasonable. We just need a way to compare them. And then the next, which I sort of alluded to, is the ability to make a change readily. So in the case of a pharmacist switching from a brand to generic, that's very easy to make. The pharmacist can do that on their own without the intervention of a physician and make that change on behalf of a consumer. So having the ability to make a medication change can also help to lower the cost. And then finally, there has to be some benefit to the stakeholders who are making that decision. In the case of a patient, patients often benefit from generics because they're paying a lower coinsurance. We can replicate that same type of benefit from a brand to generic switch between brands of different prices if the patient has a co-payment differential where they're encouraged to take advantage of a lower cost product, for example. So if the patient has skin in the game, they'll likely get the benefit of that increased marketplace competition. So what are the characteristics of a functional medication marketplace that allows for this competition to drive prices down? Well, the first thing we need is transparency. Consumers need to know what are the choices that are available, what are the prices of those choices, and what's the quality of those choices. If consumers don't have access through transparency, if they don't know what things cost and how well they work, we're not going to have a functional marketplace. In the case of generics, generics are brought to the patient often by the pharmacy. So the pharmacist is letting the patient know there's a lower cost alternative. It's a very easy switch. The next characteristic is it's a reasonable choice. So in the case of generics, generics are a very reasonable choice because they're viewed by the FDA as therapeutically interchangeable. The pharmacist can switch them, and so it's a reasonable clinical choice. In the medication, in other medication conditions, or when we think about brand-to-brand choices, many times there are multiple choices that are reasonable. We just need a way to compare them. And then the next, which I sort of alluded to, is the ability to make a change readily. So in the case of a pharmacist switching from a brand to generic, that's very easy to make. The pharmacist can do that on their own without the intervention of a physician and make that change on behalf of a consumer. So having the ability to make a medication change can also help to lower the cost. And then finally, there has to be some benefit to the stakeholders who are making that decision. In the case of a patient, patients often benefit from generics because they're paying a lower coinsurance. We can replicate that same type of benefit from a brand to generic switch between brands of different prices if the patient has a co-payment differential where they're encouraged to take advantage of a lower cost product, for example. So if the patient has skin in the game, they'll likely get the benefit of that increased marketplace competition. So what are the characteristics of a functional medication marketplace that allows for this competition to drive prices down? Well, the first thing, so what are some lessons learned here? There are often lower cost options available, and we would encourage you to look for a benefit plan that supports that healthy competition and can take advantage of the fact when there's multiple options available, that can lower the cost of prescription drugs over time.